81-year-old lady with an intertrochanteric fracture. Whenever there is a double shadow of the trochanter, normally this is a large posterior fragment which will be there. Sometimes it will be in continuation with a lesser trochanter. Whenever you see a picture like this, always you should think that there is a separate fragment, and you can see this is the one fragment and it is going in this fashion. So we'll confirm this with CT scan. When we see from anterior aspect, you can see that it is looking like a small beak, and the lesser trochanter is attached to the distal fragment. When you see here, you can see the split in the trochanter, and one fragment is with a shaft, and this is a separate neck and head fragment, and this is the entry where it is all fractured. So we have to bring them together. We have to bring them together with encirclage wire in such cases to prevent further displacement. This is the view from posterior aspect, and as you can see, this is the fragment along with the greater trochanter. This is anterosuperior iliac spine. This is the tip of the greater trochanter. A line dropping down from the anterosuperior iliac spine, and another line from the tip of the greater trochanter is our incision. As we plan to do trochanteric wiring in this case, as there is a large fragment which is having a coronal split. It's almost like a butterfly banana fragment. Only thing is the lesser trochanter is with the anterior fragment, and the I'm exposing the trochanter, and then I will be passing percutaneously the encirclage wire. Pause. Ready. Now I will pass this wire passer grazing against the bone. I will pass it as if it is kissing the bone, and I have to hear the grating sensation, and I have to go medial. Shoot. Yeah. Some more. Shoot. Yes. Now hold it. I will pass another prong of the wire passer. Again you can see that it is touching the bone. The tip is always touching against the bone, and then I lock both of them once it is inside. Shoot. Yes. Once I am able to clip this properly, that indicate that my wire is properly positioned. Now I take the prepared Drummond's wire, right angle gaya ito varti, which has been made into a cable, and artery forceps. Push. Now you can see that this wire has come on the opposite side. Now artery forceps, I'll unlock them, hold the one of the wire and take out one of the prongs, and hold this wire and take out the other prong, and now I'll tighten this wire temporarily. दूसरा थोड़ा करते उचला shoot. Yeah, I am happy with the position of this wire. After passing the nail, I'll pass one more against the greater trochanter and hold it against this wire. Right now, this is the first wire I have passed. This can be tightened. See, so nice we can do.
नेक्स्ट टाइम भेज दो बात करेंगे ना.
ठीक है. Yes, thank you. These are some intraoperative Siam pictures which shows the reduction of the fracture in AP and lateral view on a orthopedic table. On the left is the wire passer is being passed anterior from anterior aspect, and on the right, both the wire passers are being passed through the encirclage wiring. To confirm that the tip of the wire passers are opposed to one another properly, another view X-ray is being taken. This is the cable being passed around the proximal femur. Then entry is made with a guide pin medial to the base of the trochanter in AP and in center in the lateral picture. Then over the guide pin, a curved cannulated owl is passed. Then the guide pin is exchanged for a flexible long guide wire. Then the entry is enlarged with a centering owl or an entry reamer which comes with the set. Then the nail is passed. A proper owl is used to make a hole in the lateral cortex, as the guide wires are not made for drilling purpose. They bend and they skid over the cortical bone. These are AP and lateral picture showing inferiorly positioned guide wire in AP and centrally positioned in lateral view. Then the superior guide wire for the derotation screw is being passed. First, the superior derotation screw is passed by drilling with a step cut drill and then passing a proper length screw. As the name suggests, derotation screw, this has to be passed first to act as a derotational element while drilling the main cervical screw. Now, drilling for the main cervical screw with a step cut drill done. Then selected cervical screw is passed. Distal locking is done by drilling and passing a 4.9 millimeter bolt. Now I can feel the tip of the nail here. So I'll go medial to the tip of the nail, engaging this whole abductor mechanism and come out inferiorly, and my assistant will feed this wire. Feed kara. What is it? Leave.
Good.
Now, keeping this other end medial to the nail, I am bringing out the wire. Now the wire has come out. Only thing is, I'll confirm that it is medial to the nail before tightening. Yes. Now I'm confirming that my wire is not slipping over the nail, and I'm tightening both the wires together. Shoot. Shoot. Over the nail, the encirclage wire which has been passed is again tied in a figure eight manner. This is very, very useful, especially if there is a greater trochanteric avulsion fracture. These are final on-table AP and lateral picture. Well-seated nail. Both the screws are at the same horizontal level, which is very, very important. Inferiorly positioned cervical screw, a good TAD, both in AP and lateral picture. This is immediate post-operative picture showing well-reduced fracture with positive cortical support and well-placed encirclage wire. Patient is walking with the help of walker. The left lower limb has been operated. There is a drain as we have opened the trochanteric area. This is second post-operative day. Patient is walking with the help of walker, loading partial to full weight on a left lower limb. This is another case. Whenever you see a double shadow of the greater trochanter like this, then again you should think of a large posterior banana fragment. If you see this fracture plain X-ray, it appears like a avulsed lesser trochanter with an intertrochanteric fracture. But when we do the CT, then we understand better. Even the CT AP picture shows there is a avulsion of the lesser trochanter, and only the posterior antericity, the view from behind, shows that the lesser trochanter is not a separate fragment. It's in continuation with the greater trochanter. The main bulk of the fragment, the greater trochanter, is along with the lesser trochanter. If we just put a nail without fixing it, then the nail will not have much hold on the head and neck because of this displaced posteromedial fragment. So what we have to do is we have to bring them together by wiring, and then we have to do the nailing. That's what we did in this case. This is on table AP and lateral picture showing the reduction in traction. There was a negative cortical support. So with the help of a Steinmann pin, we push the beak out. Then at the apex of the beak, we applied an encirclage wire by this encirclage wire passer. You can see it, the beak is somewhere here, and this is the beak just inferior to the lesser trochanter where we have applied the wire. Then we carried out in routine fashion the PFN or 18 centimeter TFN we are done. This is a AP and lateral picture on table after passing the TFN neck screws. Then we passed a wire beyond the nail or the greater trochanter, and as only this was not sufficient, as our wire was very near to the peak here. We decided to put one more wire in the center. So this is the wire passer which is passed, and you can see there is one more wire. So these three wires are holding all the proximal fragments together, and the nail is giving the neutralization. So this is the final on table AP and lateral picture showing well positioned implant with nice reduction. This is immediate post-operative picture in the same patient. The patient was a 82-year-old, a religious leader, and he was, in spite of his fractured neck humerus on the other side, he was able to walk with minimal support at 3 weeks time. And this is at 4 weeks time. When I visited him, he was able to sit for about 2 hours to give the discourse, and you can see he's comfortably walking with very minimal support. And that time I also taught him how to climb stairs and get down the stairs. And this is the last X-ray I have of this patient at 4 weeks time, when the patient had a good function.